Well, I'd like to begin by welcoming everybody to this complimentary webinar. The title of today's presentation is Comprehensive Care for IBD Wellness, Integrating Diet and Complementary Therapies. My name is Jennifer Seminario. I'm a medical doctor at the University of South Florida and the director of our IBD research facility here. Before we begin, I want to acknowledge my disclosures, which I have with AbbVie, Janssen, Pfizer, and Takeda. So today's discussion is going to address the following topics. We want to define complementary and integrative medicine and what its relationship is to the practice of inflammatory bowel disease. We want to discuss the components of comprehensive plan for inflammatory bowel disease for the care and the wellness of our patients and review examples of these integrative therapies. We're going to define certain dietary therapies, their relationship to the medical practice in our field, and then just end with discussing the importance of communication, not only with your healthcare team, but with the different people in your life, and considering how incorporating a complementary approach can fit into your overall inflammatory bowel disease care. There's a lot of confusion that exists right now on what complementary and alternative medicine actually is. And the truth of the matter is these are just terms that we use. Complementary is exactly like it sounds. It's a non-mainstream practice in which you are using a specific therapy or practice in conjunction with conventional medicine. So they're complementing each other. Whereas alternative is something that takes the place of conventional medicine. And integrative simply is the approach of bringing everything together into a coordinated way. And so ultimately, you can have an integrative care plan that's both complementary for certain patients or alternative in other patients. And this entire approach emphasizes holistic and patient-focused care. It can often include more than just the therapies in general, but an emotional and mental, functional and spiritual approach. And basically acknowledges you being treated as an entire person instead of just an individual who has a disease. Complementary medicine is actually quite common. And as we look at statistics found through the National Health Survey, we have seen that it's used by as much as 33.2% of adults and 11.6% of children. In the United States, we often see a dietary approach incorporated as well. And in addition to this, vitamins and minerals. And we're seeing these numbers increase as time goes on. Additional complementary therapies that are used and the ones that we commonly see practiced by patients are things like yoga, osteopathic manipulation and meditation, and massage therapies. Oftentimes, the focus is on alleviating physical GI symptoms, and these patients are looking for things outside of the medical regime. They have either suffered from unwanted side effects or they have fears about adverse issues related to the medications, and they want to see what other options exist for themselves. We've looked at the reasons why patients tend to lean more towards a complementary-based approach. For some, it's specific direct disease benefits. They're looking for the optimum therapy. They're looking for the best therapy. And as we are more and more focused on our own disease states, we can search these things out via the internet, via different search engines, via organizations that put these types of options and ideas out there into the mainstream. And patients are looking for a better way to control their disease in addition to getting on the optimum therapy. Sometimes it's as simple as wanting to avoid things like steroids or a drug that they had a bad relationship with in the past and not wanting to have side effects that they have seen somebody else suffer from and or something that they themselves have suffered from. Another reason, and the reason that I think we often get confused, is that there are some patients looking for an alternative-based approach. They simply don't want to use conventional medical therapy, and they want to find what else is out there. And this could either be because of their own perception, or it could be because of ineffective treatment in the past. Indirectly, though, the idea of a complementary-based approach allows them to take over some control of their own care. And for some individuals, that gives them a better quality of life and makes them feel as if they're choosing a safer option. And we put safer in quotation marks because When we are talking about conventional therapy, we can very clearly outline safety profiles, and we as doctors can very clearly say this is what we think the risks are to medication. But sometimes just because we can say something is relatively safe, we can't be 100% sure that a bad complication or an adverse complication won't happen. And lastly on this slide, as we look towards what predicts whether or not somebody will or won't use this type of therapy, there are many different things. And it's not to say that there's one specific subtype of a patient who uses complementary therapy. This is just some of the patient profiles that we've seen who gravitate more towards this type of approach. Oftentimes it can be patients that have had psychiatric comorbidities and are looking for something that's going to help with the anxiety or even some of the mental dis-well-being that goes along with this disease. Dissatisfaction with the patient-doctor relationship, specifically if you don't have a physician or a healthcare team that you feel like understands your needs and you're looking for something that you can take control over without having to have a prescription, this offers some patients that avenue. We mentioned this previously, but side effects to conventional therapy. And this is a very common reason why patients gravitate towards this, because even if you've only had a side effects to one therapy previously, a lot of times in our mind we begin to believe that that can happen with every therapy. And using something completely different takes away some of that fear that goes along with that. As with anything in life, when we have family, friends, colleagues, or we're on different media pages or different support groups where other people have used complementary therapy and had success. Vegetarianism is something that we have seen a relationship with, and this may just go more into the reasoning of looking for holistic and healthy options, as we talked about. The last thing that we have seen as a predictor of complementary therapy use is actually longer duration of disease. And the longer that you've lived with the disease, unfortunately, and most predictive is that you may have seen more of the conventional therapies. And the disease, when left not completely treated or still active, can become worse in severity as time goes on. And when you're dealing with a disease that's worsened, as well as a disease that hasn't responded to the therapies that you've been previously put on, you're going to start to look at what other options do I have. And a lot of the times what we see in this patient population is a complementary approach. The focus groups that the foundation itself has looked at have talked about these types of discussions with different patients and caregivers, trying to understand where their knowledge base and their interest level in complementary alternative medicine comes from and exists. In these patient groups that we've looked at, everyone that is a part of the panel discussion has tried or is currently taking some form of therapy, and they split this up into 3 groups. And so what they found in this panel was that the majority of the patients that they spoke to stated that communication with the complementary therapies they were using was typically unidirectional. And what we mean by that is that a lot of the times it was the patients bringing it up to their healthcare providers and stating, this is what I'm trying, versus the healthcare providers bringing it up to the patients as an extension of their current treatment. And they found that a lot of the patients in the panel felt that their healthcare providers were reluctant to support these therapies. And some of this is based on scientific evidence that doesn't necessarily point towards effectivity or well-designed, randomized, clinical controlled trials the way that we see it in conventional therapy. And I think that some of the evidence also points towards a lack of understanding in regards to what we see in the field of complementary medicine. When patients spoke to their doctor, some of the concerns that were brought up was that these therapies are not regulated by the Food and Drug Administration. The FDA is an extremely important part of how we use and determine dosage and safety of drugs in the United States of America, as the FDA ensures that we prove that medications are both efficacious but also safe. And those are the drugs that would fall into that conventional category, whereas therapies that are complementary do not have to be followed by the FDA. So therefore, they don't require the same well-designed studies that a conventional drug is going to require to be approved. There are studies out there, but typically they are not going to have the same sample size. They're not going to be double-blinded or randomized. sometimes the outcomes aren't as clear. A lot of complementary therapy is not a part of institutional or commercial industry proprietors, and so therefore you don't have that. But with those types of environments, we get very good studies because those are some of our biggest supporters of how we come up with scientific evidence. The other thing, and we talked about this when we discussed why do patients gravitate towards complementary therapy, and one of the big reasons that patients gravitate towards it is that they had a family member, a friend, a colleague, etc., who did well on it. So a lot of the efficacy of complementary therapy is based on anecdotal reports or patient-specific stories. And this is not the same level of evidence that we would use to get conventional therapy approved. The other thing that physicians themselves are fearful of is that there's been many reports that have shown that with complementary therapy, where we talked about this additive effect of using both conventional therapy in addition to a complementary novel treatment, there are many people that will go more towards the line of an alternative approach. And so this leads to much lower adherence to conventional medical therapies. And the concern obviously lies in the fact that we don't want any of our patients to flare or for their disease to worsen or to end up with a complication because we are not on adequate therapy. I think that there's also a lot of safety concerns that you'll see within your healthcare team. Again, one of the big things that the FDA does in the United States of America is ensure that the drugs that are on the market maintain a certain level of safety data. When you aren't being followed under that umbrella, there's not that same level of guidance or somebody overseeing that the treatments are safe. And so complementary therapies can often be out there without any level of safety associated with them. And just because something is considered natural does not mean that it's safe. Lastly is the whole back and forth between a healthcare provider and you as a patient. Just like patients don't want to be told what to do and not be given a say, your healthcare provider wants to know what you're doing so that they're aware of any interactions that could be occurring. And so the lack of discussion on both ends is extremely important, and it leads to lots of concerns within this field. Ultimately, if you can find a way to maintain the open line of communication with your provider, that is the best way to ensure that this is going to be something where you can continue on it and not fear that you're upsetting your healthcare provider, as well as your healthcare provider being able to stay on top of what therapies you're doing and ensure that they're not missing any new safety signals that might come out or any new data that might come out in regards to these therapies. And this is where this idea of a comprehensive plan for IBD care and wellness comes from, is there's not just you, the patient, and the drug that you're on. There's multiple different parts to this, and any complementary therapy should be designed to make these better, just like any conventional therapy should be designed to make these areas better. For patients, beyond the medical management to reduce inflammation, which is absolutely an extremely important part of inflammatory bowel disease, there's also the diet and nutrition aspect and making sure that we're keeping vitamins and minerals within a normal range and that you're getting an adequate amount of calories, protein, and fulfilling your dietary needs without becoming dehydrated. Exercise can sometimes be very difficult in an IBD population. Sleep quality, because we know very well that the more you struggle with sleep, the more that increases stress levels, which is the next thing on the mental well-being portion of this cycle, and the more likely you are to cause an increase in inflammation. And pain management, because ultimately pain management is more than just using a narcotic or using an opioid. It's the fundamental process of making sure that you symptomatically feel well. So general guidelines for wellness and self-care for patients are eliminating smoking. As we know, this can definitely cause an increase in inflammation in Crohn's disease. But more than that, smoking is bad for your overall health. And so this is why healthcare practitioners in general try to recommend that all patients eliminate it. Limiting alcohol is the key point there. You do not have to eliminate alcohol. You simply have to limit it and do it in a moderate environment or in moderation with other parts of life that are important. Being social and being able to interact with family and friends is extremely important. Maintaining a healthy diet and meeting your nutritional needs. And there's many different diets that are out there and many different ways that an individual can meet their nutritional needs. We can, as healthcare providers, watch certain nutritional markers to ensure that you're meeting it in a laboratory setting, as well as there's certain symptomatic markers of dehydration that we can keep control of. But ultimately, it's important as an individual, as your own advocate, to make sure that you're maintaining the parts of a diet that are essential to a healthy lifestyle. Exercising as much as you can when you are feeling well is such an important part of overall care. It increases endorphins, which can decrease inflammation, as well as the fact that it makes many people's mental well-being better. That's not to say that we don't negate those patients that can't work out because the disease is so severe. We're simply saying that in whatever capacity you can find to get in some exercise, it's going to be beneficial. As I stated previously, a good night's sleep is extremely important. And again, sometimes the disease itself can make this quite difficult, especially if you're running to the bathroom throughout the night. And so ultimately, getting the disease under control becomes an important part of this. But if there are other reasons why getting a good night's sleep is a struggle, then those are going to be important things for you to mention to your healthcare provider in an appointment. And finding ways to manage stress or stress reduction. And I say this so often to patients that stress is a very easy word to say and a very difficult thing to understand. But ultimately, it doesn't have to be the same way to manage stress for every individual. We all have different ways that we relax and different ways that we entertain and have fun. And that is the most important part of stress reduction. The current knowledge regarding complementary therapy can be broken down into several categories. We can talk about the mind-body therapies, probiotics and microorganisms, vitamins and supplements, and we created a fourth category in regards to cannabis. And generally, they'll fall into these categories, again, diet notwithstanding within this scenario. Mind-body therapies are something that many individuals can incorporate into their conventional healthcare plan without any difficulty. We talked about there's higher rates of depression, anxiety, and stress that are associated with inflammatory bowel disease. This is a chronic condition that we don't have a cure for, and ultimately patients feel as if they're a ghost living with this illness because to the outside world, everything looks normal, and yet they're living with something so difficult on the inside. And so finding ways to relax and reduce that stress is so important. We, as a foundation, have looked at the different studies that have come out on this, and I've already mentioned the importance of exercise. But additionally to that, things like yoga, which is a form of exercise in and of itself, acupuncture, hypnosis, and mindfulness and relaxation techniques have all been shown as mind-body therapies that can help reduce some of the stress that goes along with this disease. Probiotics and microorganisms are what we consider a hot topic in our field right now. There's a lot of excitement and there is a lot of information that still needs to be collected and understood in regards to probiotics, prebiotics, and microorganisms. So according to the World Health Organization, probiotics are live microorganisms which, when consumed in adequate amounts, confer health and benefit to the host. So your gut or your GI tract is a mecca of different types of bacteria. It's where they live, and there are good bacteria that keep the harmful bacteria in check, sort of your guardians or your police force. And when this balance is thrown off, and many things can throw off this balance beyond just the disease and the diarrhea and the inflammation itself, medications, especially antibiotics, surgical interventions, changes in diet, all of this alter the way the bacteria that live inside of us are constituted. So probiotics are used to restore the balance of these said good bacteria. This is where the situation can become somewhat unknown, is we're trying to define how do we put back in the quote-unquote good bacteria. We've done a lot of early studies within the microbiome to get a better idea of what is a good microbial diversity versus a altered or non-beneficial microbial diversity. And what is different about the microbiome of an inflammatory bowel disease patient versus somebody who doesn't have the disease. We know that the more diverse the environment, the better. So it's important to ensure that we're not having one sustained organism living inside of our gut. And typically the way I will explain it to my patients is when I think about a bacteria that is typically not good or bad, such as Clostridium difficile, this is a weed in a sense. It's a bacteria that can grow when nothing else can. And so the more that we alter that diversity through, again, ulceration, inflammation, a constant immune attack, the more likely a weed or a bug that can grow in a very isolated environment is going to grow. We don't understand at this point in time if that imbalance of microbiota is the cause of the inflammation or a consequence. We don't know what's happening first or how it's getting there. We've looked at studies in pediatrics. We've looked at studies within gestational periods to see if there is any connection between this microbiome and what will happen in terms of prevalence of inflammatory bowel disease. And the one thing at this point in time that we can say is that this is an ongoing area of research, study, and innovation. And the microbiome is finally starting to become something that we are putting a lot of focus on as a society, not just in inflammatory bowel disease, but in multiple health conditions. Probiotics themselves, again, so as we study where they have fallen thus far in applications for inflammatory bowel disease, have been used in both Crohn's disease, ulcerative colitis, and pouchitis. These bugs, bacteria, can be found in naturally occurring foods, such as yogurt or fermented dairy products. They can also be found as part of supplements, and you can buy them in and of themselves in capsules or packets. The studies in Crohn's disease are the most limited in terms of have we found a specific efficacious subtype of bacteria, not necessarily at this point in time. But again, these studies are ongoing. However, within ulcerative colitis and pouchitis, we've found that probiotics themselves can have a beneficial effect both at inducing and maintaining remission in ulcerative colitis, as well as preventing pouchitis or cuffitis in patients who have undergone an ileoanal pouch anastomosis surgery. Unfortunately, at this point in time, we don't have very large, well-designed trials. And these are really important to determine how good these drugs are. When you design a trial in a way in which some people get it and some people don't, you try to take away variables. You try to make it as uniform as possible. Although it's true that a trial can never mimic the real-world environment, what they can do is they can try to make it as non-confounded as possible, and so that you can take patient A and patient B and make them as close as possible to each other and see if something works in one patient that doesn't work in the other. And that is why these types of trials are so important when we talk about conventional therapy. Probiotics themselves work in several ways. They can cause a competitive inhibition and increase mucus layer production. And if that's happening, they can promote protective immunoglobulins inside of our GI tract and have a beneficial response to the inflammatory effect, thereby decreasing it. So in a study, if you're looking at that and you're seeing that, what you're ultimately going to look for is a patient who has a high amount of inflammatory activity endoscopically or symptomatically or laboratory-wise, and you're going to want to see that improve. Additionally, you can restore that healthy balance that we talked about. And by restoring that healthy balance and bringing in all of the good bacteria, they themselves theoretically can lend a protective effect on the GI tract and the immune response that's being driven to attack it. The drawbacks to probiotics are that the FDA, that Federal Drug Administration, does not regulate them. And so you could see differences between one probiotic and another, and the companies aren't following certain manufacturing rules. There can be variation between bottle to bottle within the same probiotic brand. Additionally, progress has been well reviewed, but we haven't really come to that standpoint where we can say, yes, look at this trial, and this is how you should use it, and this is when you should use it. as we talk about that, we'll talk about the probiotic that has had the most impact in the field of inflammatory bowel disease, which is a probiotic known as Visbiome, formerly known as VSL number 3. This was a commercial product that contains 3 genera and 8 species of bacteria, hence the number 3. The bacteria that you will see in this are lactobacilli, bifidobacteria, and streptococcus. And this particular probiotic has been studied in both pouchitis and ulcerative colitis to its benefit. In ulcerative colitis, it's been found to have a potential benefit in mild disease as an adjunctive therapy, and the ECHO guidelines suggested that you could use VSL number 3 for maintenance and remission of pouchitis. Pouchitis is, again, in a subset of patients who have had a specific surgery for ulcerative colitis called an ileoanal pouch anastomosis. And this group of patients then has part of their small bowel created into a J shape that acts as a reservoir. Unfortunately, this is not a cure, and a lot of patients with these pouches can get an inflammation within the pouch, hence the term pouchitis. And so this is another area where the probiotics have been shown to be very beneficial. And in these studies, we've actually been able to take it a little bit further to say that you should be using this within the first week of pouch creation. So we have a little bit more of guideline type of recommendations to give to patients. There is some question in regards to Visbiome, which was formerly VSL number 3 until July 2016. And at this point in time, it's the Visbiome that you can correlate to the studies that have been posted and that have been mainstream. The current VSL number 3 is not equivalent to the prior studied formulation. Moving on is another area that patients have many questions about and many hopes for the future, and that's fecal microbiota transplantation. It is exactly how it sounds. It's transplanting fecal material from someone other than yourself into yourself. So what happens in this type of therapy is that fecal material containing gut microbiome is transferred from a healthy individual to a patient who has an altered microbiome, a recipient, just like any donor to recipient. Particular therapy is not new. We've known about it for a very long time. It has been shown to be extremely effective for recurrent Clostridium difficile infection, which was an infection that we talked about earlier that is quite common in diseases such as ulcerative colitis and Crohn's disease. That being said, the advancement of fecal transplant into other fields has taken a little bit longer. And it's not because we haven't studied it in inflammatory bowel disease. More, it has some differences in what we've seen from study to study. So on the positive side, this has the potential to induce remission, especially in ulcerative colitis. And again, by changing the flora to create the optimal flora and then allow that flora to thrive. We've seen improvements in studies not only in symptoms such as diarrhea and abdominal pain, but also in endoscopic appearance, which is very important. More data is needed because there are some safety concerns. There's been questions regarding risks of infection and death, as well as risk of causing a flare of the disease in and of itself from transplanting fecal microbiota. Right now, this is not permitted by the FDA for treatment of IBD. It is permitted for treatment for Clostridium difficile. And so if you have a situation where you have overlapping diseases, this may still be an option for you. And that's not to say that this is not going to be permitted for inflammatory bowel disease long term. We have many trials going on even as we speak, and the best place to look for more information on this happens to be the foundation, because they're constantly updating their position statement regarding fecal microbiota. They understand that this is a hot topic again and that patients want to know, where are the updates? Is this something that I can look into? And as we come up with more and more information, we are doing our best to make sure that we put it front and center for you. These studies that have been used thus far will look at a placebo where they're not actually getting a fecal transplant versus the fecal medical transplant. Some studies have looked at it just by giving it as an enema. Other studies have looked at it by inserting it during a colonoscopy. And even other studies have looked at actually ingesting it. And these are important because the entire GI tract can be involved with disease, mouth to anus. And so, these are obviously done in very safe situations, and we are doing our best to determine what's the optimal way to give it to patients. Thus far, in the major study that came out in 2017, the primary outcome showed that there was a subset of patients who got fecal microbiota transplantation who did well, who achieved the primary outcome, which was remission. And it was steroid-free remission as well as endoscopic remission. Moving on, the spectrum of understanding bacteria that are a part of this disease, there's been one specific bacteria, Mycobacterium avium subspecies paratuberculosis, otherwise known as MAP, that has been of particular interest in Crohn's disease. This is a bacteria that we've known about for decades, and it has been recognized to be found much more commonly in patients with Crohn's disease in comparison to ulcerative colitis or even healthy individuals. And there's been some evidence to suggest that it can cause intestinal illness in animal models. There's been different multi-center studies, especially in Crohn's disease, looking at a combination of anti-MAP, which is how the bacteria is typically referred to, antibiotics. Therapies that suppress the immune system are effective in Crohn's disease, but could be associated with a worsening of MAP infections because, again, when you're decreasing the immune response, an infection theoretically can worsen. But thus far, we have discounted MAP as a cause of Crohn's disease. It has not actually been found to be detected in a high percentage of patients with Crohn's disease, and ultimately may be nothing more than a co-founder or compounder. It's frequently found in people without the disease. And so that situation, combined with the fact that multiple studies have shown that therapy against MAP doesn't consistently treat the Crohn's disease symptoms nor the inflammation, suggests that this is not necessarily an avenue that plays an important role, at least in the conventional side. The foundation statement, again, is that more studies would be needed. And thus far, the studies that have been conducted in this particular field have not altered the way in which we approach inflammatory bowel disease. And more importantly, sometimes the antibiotics used to treat MAP species are quite expensive. And so using a very expensive antibiotic that has not consistently been shown to improve Crohn's disease has not gained a lot of widestream acceptance. Moving out of the microbiome and into the world of vitamins, supplements, and herbal therapies, this in a society where we are looking for healthier options just to live our best lives is an extremely important part of any inflammatory condition, specifically inflammatory bowel disease. So with inflammatory bowel disease, we do very often see nutritional deficiencies. Things like vitamin D, iron, B12, folate can all be low in our patients. And so vitamins in and of themselves are typically recommended as part of standard care as well as being monitored throughout the course of your disease. However, there's other supplements that are under investigation that may provide additional benefits when you couple them with conventional therapy. Omega fatty acids, otherwise known as fish oil pills, are therapies that have been suggested to reduce inflammation for a long time. They potentially decrease inflammatory cytokines, and those are part of the attack ensemble that hits our GI tract and causes the inflammation and ulceration. These can be a part of our diet because we can get omega-3s in the foods that we eat. Obviously, if they're in fish oil, they're in fish, and so a lot of the times we recommend fatty fish, such as salmon. But you can also get these in a liquid or a pill form. In the studies that have been conducted in fish oil, we have seen that patients with high omega-3 fatty acids have lower rates of ulcerative colitis. But unfortunately, we don't see any specific benefit for these in terms of induction or maintenance in either Crohn's disease or ulcerative colitis based on the studies that are published. So ultimately, the efficacy remains somewhat unclear and more research is needed. This is a conclusion you're going to hear a lot in the vitamin and nutritional world. We have looked at multiple different subtypes of these omega-3 fatty acids and seen which one we should really be taking our focus on. And as I talk to you about the studies, some of them have been conducted upwards of a decade ago. Some of them can be conducted more recently. But when we say that we haven't seen any, it's, again, based on smaller term studies and within subgroups of patients that aren't always blinded and randomized. That whole idea of taking two different people that look as similar as you can make them and giving one a fatty acid and one not a fatty acid. These types of trials can sometimes be difficult for us to do. But in a trial that was conducted between 2003 and 2007, the omega-3 fatty acids were not shown to be effective in the prevention of relapse of Crohn's disease. These were called EPIC 1 and EPIC 2. Moving forward on the supplements, one of the most commonly used supplements is turmeric or curcumin. This is derived from a South Asian plant that falls within the ginger family and has well-known anti-inflammatory properties and promotes mucosal healing. We have also shown that in and of itself, this can promote chemical colitis healing in mouse models. In the studies that have been done on turmeric in the IBD population, we actually are able to give a little bit of better guidance. So the two studies that we typically refer to were in somewhat similar amounts of the product. In the first 3,000 milligrams of oral curcumin was studied in patients with ulcerative colitis as complementary therapy, meaning in addition to their mesalamine therapy. And it was found to induce remission both clinically and endoscopically. Where in another study, 1 gram, which is 1,000 milligrams, was given in the AM and PM and also led to improvement endoscopically when added in addition to sulfasalazine or mesalamine. And both of these studies were double-blinded, randomized, and multi-center, which is all very good qualities to have in a study. And patients were then randomly assigned and were either given their curcumin or turmeric capsules or a placebo in addition with their ongoing mesalamine use. It should be noted these studies were not done as a primary therapeutic approach or monotherapy. They were used all in combination with the prototypical mesalamine or sulfasalazine therapy. Thus far, these are positive results. They're small studies, but they're positive results and they're well done. There is some concerns about drug-to-drug interaction with curcumin, and so it is important to bring it up to your healthcare team, but generally, this is a very safe supplement. Oftentimes, we can even cook with this, and so it's something that can be very easily incorporated into patients' daily life. Ultimately, we still need more research, especially, as we look towards incorporating this into part of the conventional therapeutic regime. But I think that it offers us something that gives more than just, here's a supplement, go try it out. It allows healthcare providers to say, okay, here's the doses that we use. And in both studies, the doses were very similar, between 2,000 and 3,000 milligrams. This slide is just made so that we can give you some of the names of the other supplements that we commonly see. It is not meant to be an all-inclusive slide, and I certainly acknowledge that there are many other complementary supplements out there that are being used, alternative supplements out there. Most of these things are considered safe, but none of these are FDA regulated. And there are some that have been shown to cause harm, both with their quality, but more importantly with the potential for side effects. Again, as I said earlier, just because something is considered natural doesn't mean that something's safe. If you look at some of the Chinese herbs, there was a study that looked at dye, and some of that study had concerns for whether or not this was causing adverse effects in patients. Another one that I often get asked about is low-dose naltrexone. Naltrexone antagonizes opioid peptides, and so what it does is it antagonizes, as we think about what we did to our brothers and our sisters as we were kids, means that we're trying to do the opposite of what they're doing. So when I say that it antagonizes opioid peptides, we're stopping the opioid peptides. So we're doing the opposite of it. And the thought is that these peptides play a role in inflammation. So if you stop them or you block them, then at low doses, this can have an anti-inflammatory effect. Glutamine is an amino acid. It's something, again, that you can take as a supplement. You get a lot of glutamine just in your diet, and again, exhibits that potential to decrease inflammation. Aloe vera is found naturally within plants, and people use this as a natural therapy in gel form to help with burns, wound healing, and you can even ingest this and to have the same effect on the GI tract, specifically more of a calming effect. Boswellia is a plant from India, again thought to have inflammatory effects, and wormwood is another supplement that we've seen, again with very, very limited studies, with an anti-inflammatory effect associated with it. But out of everything that we have seen in our field, the biggest talking point over the last couple of years has been cannabis. This is something that we as a society have studied extensively, that the foundation has made it a point to ensure patients have updated information on, and represents one of the biggest growing fields within the United States of America and beyond. So let's talk about cannabis. Cannabis is composed of cannabinoids. There are multiple cannabinoids, over 70, and they act on their receptors inside of the body, and they have different effects. The two principal cannabinoids that we all know of is THC and CBD. And these are the two that you're going to hear the most about and that are going to get the most press. THC is known for its psychotropic effect. It also does have therapeutic uses. It can help with nausea, and it can help with chronic pain, and it can help to increase appetite, whereas CBD is thought to have an anti-inflammatory effect and has been also shown useful for things like insomnia, spasticity, and again, pain. The two principal cannabinoids are the ones that we've studied the most as well. So if we talk about THC, this is the more widely known subtype, largely because of its psychotropic effect. And CBD has been the one where you've seen a lot of alternative uses, especially when there were places where THC wasn't readily available. CBD has a very high affinity for receptors, and so that's where it's getting its anti-inflammatory properties from. Cannabinoids may or may not work in inflammatory bowel disease, and this is something that was brought up as a question many years ago, and we made it a point to try and understand it better. So if you turn this into the system, otherwise known as the endocannabinoid system, or the ECS, you'll notice that it's found throughout the body. We have receptors in our immune cells. We have receptors in our neurons. And the two main receptors are just known as CBD1 and CB2. So CB1 is typically found in the brain, and it has a lesser amount of receptors in the peripheral tissue. CB2 is mainly found in peripheral organs. This is the one with the immune potential. So CB1 mainly is activated by THC, hence the psychotropic effects. It has a very weak, though, indirect activation by CBD. These receptors have been found in normal colonic epithelium, meaning they have been found in the colon. And CBD mainly has an indirect effect on CB1 receptors, whereas THC is going to have a direct effect. The CB2, on the other hand, as I said, was found in the immune cells. This has a synergistic effect with THC and a weak activation by CBD. CBD is not specific to any one part of the body or any one receptor, and it has much more of what we call a downstream effect, which is that it'll do something and then that will have a synergistic effect on multiple other things, and so its effect in one place leads to multiple things moving forward. With regards to the pain effects associated with CBD, there has been some data that it does overall help with pain, sometimes with headaches and lethargy, but ultimately the THC has more of that psychotropic effect than it does a prominent pain modulating effect. The consensus statements from the foundation are as such, and I'll read them exactly as they're written. The Crohn's and Colitis Foundation supports policy changes that facilitate the conduct of clinical research and the potential development of cannabinoid-based medications, including further consideration for revising marijuana status as a federal Schedule I controlled substance. That's where they say, and so I think what I take from that and what I think patients should take from that is the ongoing ability to adapt to what we know. And just because we say something today doesn't mean that that's not going to change with the new onset of information that comes in the future. That being said, if we're taking the studies that we have available to us right now. With Crohn's disease, in the one randomized controlled trial, there was no change in clinical remission rates with cannabis. There was no change. In patients with ulcerative colitis, there was improved quality of life. Patients felt better. However, there was no difference in remission rates in patients with inactive ulcerative colitis. There has been some benefits that we have seen with cannabis in inflammatory bowel disease, specifically with regards to quality of life measures, but no studies have shown a significant impact on disease activity. There are no known side effects to short and sometimes long-term use, and those side effects include things like hyperemesis and pain. There's even been recent studies suggesting cognitive impairment in younger individuals using cannabis. And so understanding that there are known side effects and that there are no studies that result in changes in inflammation or remission rates with cannabis, this is typically a therapy that we do not recommend stopping conventional therapy to do. I think that it is extremely important for my patients to understand that I'm going to be supportive because I want them to be honest with me. But I also think it's important for you as patients and your own self-advocates to understand the information out there. There is very, very good quality of life data. There is no data in regards to inflammation. And I say that a lot in the last couple of seconds here just because I really want to make sure that it's important that I state things that are factual in a talk like this. And I think that being said, it doesn't mean that it's not something I don't recommend. In fact, I have many patients who find this to be very, very beneficial. I think at the end of the day, making sure that your doctor is aware of what you're doing, and if you do have a plan to discontinue your conventional therapy, ensuring that somebody's aware of it so that a contingency program is put in place on the chance that stopping conventional therapy is going to lead to worsening of disease is the most important thing that we can ask for. Next, we're going to talk about diet, and I think that diet is right up there with cannabis on top questions that I talk to patients about. Diet's a fundamental component of our lives. We need it to survive. It's a component of medicine, and although information studies right now suggest that diet alone is not completely efficacious, it should be considered a part of complementary therapy. Diet can improve symptoms of inflammation. It can change your microbiome. It can alter the mucus layer. It can change permeability. And diet has been studied as its own treatment for inflammatory bowel disease, especially in the pediatric population with enteral nutrition. There are several studies going on right now looking at specific diets in Crohn's disease. These diets are known as the specific carbohydrate diet and the Mediterranean diet. There's also a Crohn's disease exclusion diet. And although we don't have a specific, this is the Crohn's diet that you should be on study yet, we are for the first time making sure that we look into these different diets and come up with some actual data instead of just patient testimonials. Enteral nutrition for Crohn's disease is a little bit different. So this is where patients are exclusively given enteral feeds, where we're putting it into their stomach without actually eating a regular meal. And research has been done on this field, especially in Crohn's disease, that this can be a bridge to surgery by giving the GI tract rest. It can specifically allow physicians or healthcare providers to know exactly what's being ingested by our patient. It has been shown to induce remission and cause endoscopic healing. And again, as I stated before, this is a commonly used practice in pediatrics in comparison to adults. It's very difficult to adhere to, and it can sometimes be a tough strategy to get patients to buy into. Partial enteral nutrition, a little bit easier. This is where you do a liquid formula plus you consume food. And again, we've seen clinical and endoscopic improvement with this type of diet and ability to maintain remission, but there's some conflicting data. And so we don't see one universal language for how we should do that. The specific carbohydrate diet studies is a diet where you exclude complex carbohydrates in favor of more simple sugars. It's a very strict diet, and it has a lot to do with compliance, but it can very much help with quality of life. Small studies have been done thus far looking at things like the fecal microbiome, symptoms, and inflammation, but there are two large-scale multi-center studies, and they're ongoing currently. One is PRODUCE, which is being studied in pediatric patients. The other is CD-DINE, And this is a study that's going on in adults through the foundation. So this diet itself was developed in the 1920s, and it was popularized by the book Breaking the Vicious Cycle. And it essentially minimizes available substrates for bacterial fermentation. It's rigid. Anecdotal cases in children do show improvement, but data in adults is not as robust. Adults are very difficult to get to adhere to a specific diet, and it does require very, very good compliance. But the positive to this diet is that there's a lot of liberalization that occurs after a certain period of time on the diet. So let's talk about the Crohn's disease exclusion diet. This is a whole food diet, and this essentially means that you can have fruits and vegetables and meats, complex and simple carbohydrates, plus partial enteral nutrition. So what's not allowed? Baked goods, yeast, gluten-free, potato flour, corn flour, things like that. Processed foods are going to be more on the no side. Canned foods, certain candies, and alcohol and coffee. There was a 12-week trial that was done in children with mild to moderate Crohn's disease, and they were either assigned to this diet, and they got 50% of their calories from formula, versus enteral nutrition with 25%, or a group that received exclusive enteral nutrition where they weren't allowed to eat anything, followed by a free diet after 6 weeks. So ultimately, the Crohn's disease exclusion diet plus partial enteral nutrition was a better tolerated diet than exclusive enteral nutrition, which makes sense. Both diets were effective, and they could induce remission, and they induced a sustained remission in a significant amount of patients. It's a matter of whether or not this could become a mainstream diet for people. At the end of the day, the biggest thing that we can learn from today is having an open line of communication and being able to discuss the therapy that you deem most fit with your healthcare team. Questions to ask your healthcare provider. Are there any therapies or diets that you know of that have been studied? Let them tell you what they know. What benefits can I expect? What benefits should I look for? How do I know if what I'm on is working? And this holds true for conventional therapy or complementary therapy. Is there a risk that doing this will interfere with my standard IBD treatments? I don't ever get tired of getting asked these kinds of questions, and neither will your healthcare provider. They would rather you ask it, and there are no stupid questions, because knowing that what you're doing is okay is going to take away some of the anxiety that goes along with doing it in the first place. Potential for side effects can sometimes be a difficult question to ask, but ask it, because there are several supplements, therapies that are associated with side effects. And is there anything specific that you would advise against? And there are different scenarios in which your healthcare provider may advise against something for you. There are many different diets out there, for instance, that are quite restrictive and sometimes can restrict you in a way in which you're not getting certain vitamins that are important to your underlying Crohn's disease or ulcerative colitis. So this is always going to be an important question to ask and to discuss. And I think that when you move towards what do I consider, what should I think about, making sure when you fill out the paperwork at your healthcare team's office that you're listing all your therapies. Even if you don't know if it should be on there, the worst thing that can happen is you list it and nobody pays attention to it. Also, consider your own food allergies and intolerances, because sometimes these supplements, again, are not FDA regulated, and you really want to get a clear idea of the ingredients in everything you're using. And making sure that your healthcare team is monitoring you no matter what you're on for nutritional deficiencies, vitamin deficiencies, malnutrition. At the end of the day, we recommend as healthcare providers that we follow evidence-based rationale whenever we can, understanding that evidence-based rationale does not take into consideration every single person's individual circumstance. So in summary, complementary therapies and diet in inflammatory bowel disease is such an important part of our future. It's a part of where we'll go and how we'll be better able to understand and fight this disease. We went over some of the common complementary therapies that have been studied, and we went over the fact that unfortunately there's limited data at this point in time, but that hopefully long term, with more understanding and more emphasis into this field of medicine, we may be able to find out more information and answer more questions and develop better strategies to improve your symptoms. At this point in time, there is no data that supports complementary or alternative therapy, I should say, as a replacement to traditional IBD therapies. I think that as a complementary therapy, that this is a very, very important part of our regime. It's just knowing that if it is an alternative, we can't give you that piece of information and or data that this is going to be superior to the strategies and conventional treatment options that have been shown to put the disease into a remission state or a period where it's not as severe as it was. More studies are needed, and I think that as I maintain a part of this field and a future in this field, this is something that we will see coming, and I think that more and more healthcare providers are acknowledging that it is an important part of it, and I hope that if you gain anything from this, that at least you understand that this is something you shouldn't be fearful of to bring up to your healthcare team. It should be something that needs to be discussed and addressed. Lastly, as we get towards the end of this presentation, I want to take a minute to thank everybody that was involved in it. The slide contributors are a part of my patient education team through the foundation, and I'm very lucky to be a part of this group. These healthcare providers take time out of their practice to help build these types of programs so that we can present them to patients and give the up-to-date information and the up-to-date analysis of what's going on. And so I think it's really important to know that at the end of the day, our job as healthcare providers are to help make you better, and that's what we're out there trying to do. And there's even more reason to try to make the healthcare providers and the healthcare team a part of the entire approach instead of ever being afraid to mention everything you're doing out of fear of retaliation. Because at the end of the day, the only thing that matters to any of us is trying to get you better. But most of all, I'm grateful to the foundation and that I get to be a part of it. And I fully recommend that you take time to go to the foundation website to not only look up things like complementary therapy and conventional therapy, but everything that's in the pipeline for the future and everything that the website has to offer for patients. We talked about many things today, but there's so much more that goes with this disease. And the foundation is constantly striving to update the website and update educational materials for patients and healthcare providers throughout the country. And I think that this is such a great asset to our patients and such an amazing organization to be a part of. Thank you so much, and I hope that you all enjoyed the presentation.